Think about the fact, even the curriculum. I'm happy to see APHRCs in Kenya, Save the Children, and my Australian partners. We really need a curriculum that is examinable even for healthcare providers in adolescent and youth health. We have for maternal, we have for the neonate, we have a big gap addressing the adolescent, which then speaks to us on legislature, policy environment, and having the best standard of health for this age cohort. Think about the reasons why we should be having contraception even amongst this age group, considering they are not a homogeneous group, they differ. Think about even that adolescent where we are battling and struggling with gender and sexual orientation issues. We need to really look at it with a globus attitude. And globus means no one should be left behind. FIGO, PMNCH are two bodies that have clearly said the adolescent must remain on the map. But being on the map and implementing direction to actually save this most important capital for any nation, the adolescent and youth, so that they reap the demographic dividends for the nations they belong to and not remain disillusioned and lost. And unfortunately for some, even dying. I am certainly looking forward to being part of this webinar and even looking beyond the webinar. How can we collaborate and get into a partnership to make an indelible difference, because they matter like everybody else. Thank you very much.
Fantastic, Professor Kihara. Thank you so much for starting our webinar off with such power and such force that is needed to bring attention to this area. That was Professor Kihara, who is the president of the FIGO, the International Federation for Gynecology and Obstetricians. And I think she's just really set the scene for this webinar. I'd like to thank her for joining us, and we look forward to hearing more from her about what FIGO will do for the next 2 years in the next upcoming webinar in June. Thank you very much, Professor Kihara.
So much. Thank you very much. Have a beautiful, beautiful webinar.
Thank you. Thank you. We will keep in touch. Take care, Dr. Kihara. Now, this webinar, as I mentioned, is a collaboration led by Save the Children and the Africa Population Health and Research Centre and the Centre for Adolescent Health at the University of Melbourne, where I am based. I'm Dr. Farnaz Sabet, and I have the privilege of being your moderator today for this webinar. If we go to the next slide, please. This will show you what the webinar will cover today. We're going to start with what we know about the global MNH needs of pregnant and parenting adolescents by Victoria Luesha from Save the Children. Then what are the lived experiences of pregnant and parenting adolescents with a greater Africa focus from Dr. Anthony Ajayi from the African Population and Health Research Centre. Then focusing even more on Nigeria. Nigeria is very critical, actually, because it has the highest number of adolescent births globally. It's exceeded India in recent years. And we're going to have some insights from qualitative research recently done by Dr. Christiana Alex Oje from the Federal University of Oyo Ekiti in Nigeria. And finally, going to the Ministry of Health perspective, we're looking at MNH needs regarding adolescent MNH needs in country policies, strategies, guidelines, and data. And we have Dr. Alan Kasozi from the Ugandan Ministry of Health. Please keep the questions coming and introduce yourselves in the chat box. Next slide, please. We'll start first with Victoria Luesha, Advisor for Adolescent Maternal and Newborn Health and Family Planning from Save the Children. Over to you, Victoria.
Thank you so much, Fanazi, and thanks, Professor Kihara, for setting the ball rolling. I'm going to talk to you about the MNH needs of pregnant and parenting adolescents from the work that Save the Children led through literature and landscape review. Next slide. So globally, adolescent pregnancy remains high, and it leads to poor outcomes for the adolescents themselves as well as the newborns. And at the same time, global attention has focused on preventing adolescent pregnancy, yet we still see that millions of adolescents are still giving birth. For example, we see from the literature that approximately 12 million girls aged 15 to 19 years and at least 777,000 girls under the age of 15 years give birth every year in developing regions. And this has led to complications from pregnancy and childbirth that are among the leading causes of death for girls aged 15 to 19 years globally, meaning that this is an issue that we need to be focusing on. Next slide. So because of the pregnancies, adolescents and the newborns face higher risk of morbidity. Literature shows that there are some medical conditions and complications that occur more commonly in adolescents, for example, eclampsia, puerperal endometritis, and systemic infections, compared to their counterparts aged 20 to 24 years. At the same time, we have about 40 to 50% of neonates that are born from adolescents who are more likely to be born preterm, but at the same time, they also experience severe neonatal conditions. Next slide. In terms of mortality, we also see a similar picture where maternal mortality is estimated to be about 28% higher among adolescents compared to their counterparts aged 20 to 24 years. And as I mentioned earlier, complications in pregnancy and childbirth are higher among adolescent girls that are aged 10 to 19 years compared to women aged 20 to 24. And we also see a similar picture with stillbirths and newborn deaths that are 50% higher among infants of adolescent mothers than among infants of women aged 20 to 29 years. And we also need to put in place some ethical considerations there, which suggest that efforts to reduce maternal mortality rate should be directed towards those that are most at risk, for example, adolescents. Next slide. So as I mentioned earlier, Save the Children embarked on a literature and landscape review in 2020 and 2022, respectively. We wanted to understand why adolescents are vulnerable to poor MNH outcomes. Next slide. So we have this pathway framework that helped us to pull together what we managed to get from the literature and landscape reviews. We found out that adolescents and their newborns face a number of vulnerabilities, and these vulnerabilities exacerbate the barriers which lead to reduced use of quality MNH services, and subsequently we have poor MNH outcomes. So in terms of vulnerabilities, we have biological vulnerabilities that relate to physiological immaturity that directly lead to poor MNH outcomes. And therefore, there is increased risk of maternal and newborn morbidity and mortality. Apart from the biological vulnerabilities, we also have developmental vulnerabilities, which relate to social, emotional, and cognitive changes that happen during the adolescent period. And we also have social vulnerabilities, which relate to age, gender, and life stage. And these, as I mentioned earlier, exacerbate the barriers to quality MNH services, and they complicate the transition to parenthood. And these barriers at different levels of the socio-ecological model, at individual level, family and household level, community level, service delivery level, and policy level. And as I mentioned earlier, this led to reduced use of MNH services, and later they increase the risk of maternal and newborn morbidity and mortality. We will now dive deep into specific discussion on the biological, developmental, and social vulnerabilities. Next slide. So in terms of biological vulnerabilities, which I mentioned earlier that they relate to physiological immaturity and they lead directed to poor MNH outcomes, we have specific examples of how this works out and what happens during adolescence. So the growing adolescent competes with the growing baby for nutrients in pregnancy. And at the same time, for the adolescents that are less than 15 years of age, they have an immature pelvis and they have the risk of developing obstructed labor. But the situation is a little bit different for older adolescents that are 16 to 19. And for these ones, they are less likely to deliver by cesarean section because of the smaller baby size. But at the same time, they are at risk. Next slide. And for developmental vulnerabilities, we have changes that happen in the developing brain of the adolescent, and this compounds the risk of depression and anxiety. But at the same time, they are influenced a lot by the peers, and this contributes to their risk perception, as well as issues of care seeking and adoption of positive behaviors. As for social vulnerabilities, which relate to age, gender, and life stage, the adolescents have limited agency, resources, and decision-making authority. But at the same time, for adolescents that are unmarried, these ones are more likely to deny their pregnancy, and they are undecided about taking the pregnancy to term. And there are a lot of issues that relate to social stigma around pregnancy outside marriage. Next slide. So as I mentioned earlier, the adolescents have vulnerabilities, and the vulnerabilities exacerbate the barriers that these adolescents face. Much as these barriers are faced by all mothers, they are the adolescent pregnant women face more challenges because of the vulnerabilities. And my colleagues, Dr. Anthony and Christiana, will talk more about the experiences of these pregnant parenting adolescents and also how they have managed to navigate them. Next slide. As a result of these vulnerabilities and the barriers, we see that the adolescents are less likely to seek antenatal care services early, and they are less likely to complete the recommended visits. They are also less likely to deliver at the health facility, and they are also less likely to use postnatal care services for themselves and their babies. But we should be clear that there are inter and intra-country variations when it comes to these data. Next slide. They are also less likely to receive quality MNH services compared to adult women. They are less likely to receive all the components of MNH care. We have examples of access to receiving antenatal corticosteroids in some contexts, and they are also more likely to experience disrespect and abuse during delivery. We found some data and literature from Ghana, Guinea, Myanmar, and Nigeria. Next slide. So in conclusion, the adolescent pregnancy rates are high. Globally, we have focused on preventing adolescent pregnancy, which is right and it's urgently needed. But at the same time, we need to put in place interventions and approaches and the focus and the attention to the needs of pregnant and parenting adolescents. And lastly, as I mentioned earlier, some of the disparities that these pregnant parenting adolescents face may be due to the vulnerabilities that they have, and these vulnerabilities are likely to exacerbate the barriers to access and use of quality responsive MNH services. Next slide. Thank you so much, and I'll hand it over back to Dr. Farnazi.
Thank you, Victoria, for that really comprehensive and evidence-based presentation. We now move to Dr. Anthony Ajayi, a research scientist at the African Population Health and Research Center, who is going to focus more on the experiences of pregnant and parenting adolescents in Africa. Over to you, Anthony.
Yeah, thank you very much, Dr. Fenas. Let me begin by saying that this scoping review study was done by a team of researchers at the African Population and Health Research Center, some of whom are on the call. Special mention to Dr. Caroline Kabir, who led the team. Next. So here are the main takeaways from my presentation. Most adolescent girls describe their pregnancy as unintended, resulting from sexual violence and exploitation, transactional sex, as well as inaccurate information on methods of preventing pregnancy. However, a few adolescents also desire the pregnancy. Many of these category of adolescent mothers were already out of school or married before they become pregnant. Pregnancy for most of them, even all of them, initiates or culminates into a cycle of social exclusion from family, school, partner, friends, health facilities, communities, including churches. Girls face worsening financial challenges, stress, anxiety, and deprivation. Next. As we've heard previously, pregnant and parenting adolescents face daunting challenges as they navigate parenthood. I mean, being pregnant as a child and raising a baby as a child, it's not an easy task. And as a result of these, many forfeit their future aspirations, including their educational goals, as well as also forfeit skill acquisition opportunities. All these have implications for their immediate and future health and well-being, as well as that of their offspring. So given the unique challenges facing this cohort of adolescents, it is pertinent to review the literature to identify gaps in research on this population. Also noting that the population of pregnant and parenting adolescents is quite huge. We are talking about millions of young girls becoming pregnant or mothers at such a young age. So there is a need for targeted intervention for these categories of young people. All this motivated us to conduct a scoping review to understand the state of evidence on young people. Next. So we set to answer 3 key questions. We wanted to understand the profile of research and lived experiences of pregnant and parenting adolescents in terms of the research design, geographical distribution of evidence, the substantive focus of these studies on the continent. Also, we wanted to understand how early childbearing impacts the mental health of pregnant and parenting adolescents, as well as what intervention are assisted that are reaching adolescent mothers to improve their social health and socioeconomic well-being. Next. So we searched the literature for papers published between year 2000 and 2021, and we were guided by the Joanna Briggs Institute's methodological approach to conducting scoping review. And we reviewed both peer-reviewed papers as well as grey literature. But the grey literature was limited to technical reports and academic thesis. Next. So overall, what we found that about 2 in 5 studies were conducted in South Africa, showing the geographical skewness of the studies published. There were countries without papers, and most of the study adopted qualitative design, and only a few theses and reports were included in our review. Next. So we summarize the results under a few thematic areas. One is circumstances surrounding adolescent pregnancy. And as I mentioned in my main highlight of this presentation, most adolescent girls describe their pregnancies as unintended, resulting from transactional sex to meet their basic need as a result of sexual violence and exploitation and inaccurate information on methods of preventing pregnancy. Some that were happy about the pregnancy were said they were happy because now becoming pregnant commands respect from people in their community. So it boosts their status within the community. But these categories of girls are either married or out of school before they become pregnant. For most of the girls that reported their pregnancy and unintended, the pregnancy Their reaction is feelings of disappointment, anger, regrets, anxiety. While for those that wanted the pregnancy, they reported a sense of satisfaction, happiness, and accomplishments. Although those are for a few categories of them. But what's also important to note is that most of these pregnancy occur when adolescents are still in school. So the category that were unhappy about the pregnancy are actually the larger proportion of pregnant and parenting adolescents. Boys also were reported to deny paternity because they thought admitting to be the father, the owner of the pregnancy, would jeopardize their education and employment opportunity. And as a result of that, adolescents' mothers had limited support from boys or their parents. I think what's also important to note is that there are few adolescent fathers that also accepted responsibility. And in fact, there are cases where some of them would juggle between work and schools just to be able to provide something for their partner and for the baby. Next. So the second thematic focus is challenges facing pregnant and parenting adolescents. And for most of these girls, they experience extreme hardship, educational disruption, stigma, stress, loneliness, guilt, and harsh treatment from their family, from schools, from hospitals, as well as from the members of the community. They face financial constraints and food insecurity, prompting some of them to take up menial jobs. They face unfavorable health outcomes emanating from discrimination by health workers. Their pregnancy is seen as a major impediment to their education, their career aspiration. And although there are countries that have formulated policies on school reentry, what we found is that most pregnant and parenting adolescents are out of school, and others are forced into early marriages and left feeling rejected. Now, two studies also reported that adolescent mothers have limited knowledge and skills about newborn childcare practices, and that they often resort to harmful practices. For example, they apply hot towels with hot stones to the child's umbilical stump. Next. We also another thematic area is the mental health of pregnant and parenting adolescents. And what we found is that depression is common among pregnant and parenting adolescents, and it ranged from 13% in Zimbabwe to as high as 53% in a study in Kenya. And a common risk factor for poor mental health among adolescent mothers include verbal abuse, physical violence or physical abuse, low family income, psychoactive substance use, HIV diagnosis, lack of social support, abandonment by partner, parental absence during childhood, social insecurity, and bad relationships within families. But partner support as well as family support are important protective factors. Also, despite the mental health challenges they face, they lack access to mental health services due to negative providers' attitude, stigma towards mental illness, and adolescent pregnancy, and lack of confidentiality and logistics, as well as environmental challenges. Next. The last thematic area is adolescent pregnancy and maternal health care access. For most adolescent mothers or pregnant adolescent girls, they delay in seeking antenatal care. In fact, a study in Tanzania shows that 70% of adolescents had their first antenatal care visits in the 5th month of the pregnancy. And that is even much higher in Kenya, where a study reported that up to 88% of them had their first antenatal care in the 2nd trimester. And this is also due to lack of recognition of the pregnancy, denial of the pregnancy, as alluded to by Victoria, lack of autonomy in decision making, lack of knowledge about antenatal care services, their young age, Also because they hide the pregnancy, because they fear the ramification that befall them as a result of the pregnancy. Also, they experience mistreatment and abuse in clinic. In fact, a study in Kenya that showed that 32% of adolescent mothers reported physical and verbal abuse, as well as stigma and discrimination. And this figure is as high as 60% in Nigeria. Next. So in conclusion, studies on pregnant and parenting adolescents are limited in scope. Of course, we know a lot about the lived experience of pregnant and parenting adolescents, but much of the studies were conducted in South Africa. So many other countries still do not have studies to guide policy discussion, debates, as well as policy formulation. Pregnant and parenting adolescents face, a myriad of challenges with their implications for their physical and mental health, and there are few rigorously tested interventions reaching adolescent mothers. Thank you. I will hand over back to Dr. Fanas.
Thank you so much, Anthony, again for that great overview on the challenges that pregnant adolescents face in Africa. Can I ask that my colleagues Victoria and Anthony to please put on your videos? We have some quick questions now. I want to thank Nahal for adding a question in the chat box. We'll get to that, to the Q&A box. We'll get to that question at the end. For now, there was a question that has come up about, because everyone mentioned the barriers, but one thing that was missing was the legal barriers that adolescents might face. So Victoria, could you give some brief comments on that, followed by Anthony, either enablers or barriers from the legal perspective?
Sure. Thank you so much, Fanazi and Anthony, for the presentations. And I just wanted to touch on the issue of legal rights and issues of barriers. From the literature and in most of the context, we see that the adolescents have challenges, but sometimes they also have opportunities in terms of their rights to give consent, especially to medical care. That's the angle that I would want to take. So when you go to health facilities, there are two aspects. Adolescent clients are expected to involve or engage their parents in their medical care, but at the same time, they have the right to receive the care that they need. So it's a requirement or an expectation on the health care providers to be able to understand the legal frameworks in the specific countries and in terms of what they say as it relates to providing care to pregnant and parenting adolescents, but also in terms of sexual and reproductive health and rights. But in terms of the specific issues around pregnancy for adolescents and relating to issues of age for sex consent, in most of the countries that we have worked in and where we managed to identify literature, it's around ages 16 to 18, but we still see that these adolescents are getting pregnant, much as we have these legal frameworks in terms of age of sex consent. And when the adolescent gets pregnant, we have had situations where the partners that have impregnated this girl will sometimes deny the pregnancy because the legal framework is criminalizing them when they have accepted that they are responsible for the pregnancy. And this now contributes to the adolescent not receiving the support that they need to be able to access care, to have access to financial support, and they have to rely on the family and caregivers to receive the support that they need. So what is really important is to make sure that we support healthcare providers to be aware of the legal framework and to be aware of the rights of the adolescents because they need this care and service. We call them mothers, but they are still children that are having other children, and at the same time, they need to be supported to be able to transition to this role, and at the same time, be able to thrive and survive with their life and achieving their full potential. Thank you.
Thank you very much, Victoria. Anthony, is your video working, or should we try you? You have any quick comments to add?
Okay, so for me, I will probably share from a policy perspective. So, for example, many countries on the continent has free maternal health care policy, but there are requirements for you to register. You need to have an ID, and in many countries, you have to turn 18 to be able to obtain an ID. So this is also one of the reasons why adolescent delay in seeking maternal health care services, because so for them, many of them cannot afford the services. They have no jobs, and their parents are also struggling. So it's really pertinent for them to be able to access the free maternal health care. But unfortunately, because of their young age and lack of ID, they are unable to register for the free maternal health care card. So often they navigate that by having their mother register on their behalf as a way to bypass it. But these are some of the policy consideration for the policy drafters to to keep in mind that they're also making policies for adolescents, mothers, and find a way to accommodate them so that they do not delay in seeking care as a result of their young age. Thank you.
Thank you very much, Victoria and Anthony. I think we will also be covering some of this aspect in the second webinar from an Indian perspective, also in terms of the legal implications around access to care. Let's now move on to our next presentation. Next slide, please. As I mentioned, we're going to do a deep dive into Nigeria. We have Dr. Christiana Alex Oje, who's a lecturer at the Department of Demography and Social Statistics from the Federal University of Oyo Ekiti in Nigeria, and we look forward to hearing her insights. Over to you, Dr. Christiana.
Thank you very much, Dr. Fanaz. Like has been said earlier, I'll be speaking on a qualitative investigation into pregnancy experiences and maternal health care utilization among adolescent mothers in Nigeria. Next slide, please. So, as has been said, I believe Dr. Fanaz mentioned earlier about the fact that Nigeria has overtaken India as the country with the largest number of adolescent mothers in the entire world. As of 2019, the 2018 DHS survey in Nigeria found an adolescent fertility rate of 106 births per 1,000 women of that age group. And as we mentioned by Victoria and Tony, adolescent pregnancy is rife with risks. Adolescent mothers have highest risk of obstructed labor and death. Next slide, please. All right. So there's also a social backlash to adolescent pregnancy. I believe Tony has mentioned this earlier about the fact that adolescent mothers also face stigma in different contexts. And going forward, so far, little is known about the pregnancy experiences of adolescent mothers and the factors within their socio-cultural environment serving as enablers or for barriers to healthcare usage for them. Next slide, please. So the study had two research objectives. The first is to explore adolescent mothers' pregnancy experiences across Nigeria, and also to identify factors serving as barriers and enablers of maternal health care utilization among adolescent mothers in Nigeria. Next slide. The study used a qualitative method. Data were collected at 6 research sites between November 2018 and January 2019. Adolescent mothers were drawn from rural and urban communities in 3 states, one each: Katsina State in the north, west, Ondo State in the southwest, and Imo State in the southeast. As at when the study was conducted, each of these states had the highest adolescent pregnancy rates in their respective zones, and Katsina State in the northwest had the highest overall rate of adolescent pregnancy. Were collected using in-depth interviews from 55 adolescent mothers, that's mothers between ages 15 and 19, and 12 women who were mothers themselves to adolescent mothers. The data were analyzed using the thematic analysis method. Next slide, please. So resulting from the study, we were able to draw out 2 major themes and 6 sub-themes. The first major theme was pregnancy experiences of adolescent mothers across Nigeria. Under this theme, we had things like pregnancy intention, stigma attached to adolescent pregnancy and social support during pregnancy. The second major theme was pattern of healthcare use and associated factors. And the first sub-theme on that was affordability and misinformation about the cost of healthcare, health worker attitudes, and personal and community preferences. Next slide. So we found out that, first of all, unmarried adolescent mothers expressed shock and surprise, just like my colleague Tony said earlier. Unmarried adolescent mothers, most of them, when asked, they said they did not expect to get pregnant, they did not intend to get pregnant, they did not know they were going to get pregnant. That was a very common thread among them. For married mothers, especially in the northwest part of the country where early marriage is normative, for them it was an expectation, okay, once I get married, the next thing for me is to get pregnant. So they were more accepting of their pregnancies. Now, as my colleagues have also mentioned, adolescent pregnancy comes with a stigma. And this was especially found among unmarried mothers. You know, some of them had things like verbal abuse. Some were told outrightly to go and abort their babies. Some were ridiculed for getting pregnant. There was a particular mother who even reported that her schoolmates, her classmates came to her house to make fun of her because they found out that she had gotten pregnant. So stigma was a recurring occurrence, especially among the younger and unmarried adolescent mothers. Next slide. Then we found out that adolescent mothers were largely dependent on their family members. I believe that Victoria explored the issue of social support. Adolescent mothers were largely dependent on their family members and spouses for emotional and financial support. Now we found out that unmarried mothers relied more on their mothers. Their mothers were the major source of support for them during their pregnancy, while married adolescent mothers focused more on their husbands and their husbands' families for support. And in just one case where, you know, the husband and his family were unwilling to provide support, the mother of the adolescent mother, that's she had to go back to her natal family to provide that support for her to enable her, you know, be able to survive the pregnancy. Next slide. So we found out that under the theme patterns of healthcare and associated factors, we found out that affordability and misinformation about the cost of healthcare was a big issue. For instance, adolescent mothers used health facilities or alternative providers that they felt that they could afford. Where they felt that they could not afford modern healthcare facilities, they went to make use of alternative providers. Now, the issue of misinformation comes up because they found out that it was found out in the course of the study that some of them thought using the modern healthcare facility was expensive, but it was actually not as expensive as they thought. In fact, in some cases, some ended up paying more at the alternative providers than they would have paid while using the modern healthcare facilities. Then the issue of health worker attitudes also came up. While this did not necessarily serve as a barrier, but it was, you know, an important enough occurrence to take note of. They found out that some, while in not many cases, you know, were reported of having negative health worker attitudes, but some others reported things such as verbal abuse, insult, carelessness on the part of nurses, and some sort of nonchalance. You know, some of them were told to go away, they are not in labor, they should come back later in the day, because the nurses were just not willing to give them the necessary support that they needed in labor. Next slide, please. We also found out that personal and community preferences, you know, influenced maternal health care utilization among them. For instance, their mothers, the thoughts of the mothers concerning healthcare served to influence the type of adolescent, the type of maternal health care adolescent mothers use. For instance, where mothers felt that, you know, it was better to use the hospital than their daughters use the hospital, where the mothers felt it was better to use alternative providers than their daughters made use of alternative providers. Then again, adolescent mothers made use of the types of healthcare that were seen as normal within their communities. In the Northwest Research Site, for instance, it wasn't common, especially in the rural area, it was common to use antenatal care, have the baby in the house using the traditional birth attendants, then go back to the health center for postnatal care for the baby. So asking the adolescent mothers, they'll say, yeah, that's a normal thing. So that's what we did. So the type of healthcare that was seen as normative in their environment was what they ended up going towards. Again, we know that adolescent mothers and adolescents generally are easily influenced. Next slide, please. All right. So in conclusion, we found out that there was a large number of unwanted pregnancies among adolescent mothers, especially the unmarried ones, as well as stigma. Stigma is quite rampant against adolescent mothers. We found out that factors such as social, economic, and emotional support were important influences for healthcare use, as well as healthcare preferences. These had important influence on healthcare utilization among adolescent mothers and the types of healthcare they were able to use. Not wanting a pregnancy, negative healthcare workers, and stigma, while they were present in some form, they did not really have so much influence on the health-seeking behavior of adolescent mothers. So thank you very much for listening. And now I'll hand over back to Dr. Anthony. Thank you.
Thank you, Christiana. That's great. We're actually going to skip this in the interest of time. We do have a video. If we have time at the end, we'll go to it. But we also really critically need to hear the Ministry of Health perspective about what are the considerations for reflecting adolescent MNH needs in country policies, strategies and guidelines and data. And we're very happy to have Dr. Alan Kasozi with us today to speak about the perspective from the Ugandan Ministry of Health. Dr. Kasozi, are you on? There's been some internet challenges with his connection. Let's just wait a couple of minutes and see if he's... Oh, excellent. Okay, I'll pass it over to you. Thank you.
Right. If you may just allow me share my screen.
Dr. Kasozi, we have your slides up here on the screen and we'll advance them for you.
All right. So are you able to see my screen?
Yes, we can see it.
All right. Thank you for hosting me onto this webinar. I'm Dr. Alan Kasozi from the Division of Adolescent and School Health. I will start
Dr.
right
Kasozi,
away.
can you please make it full screen so we can see it clearly? Is it possible?
All right. Is that better?
Oh, now we've lost you. Do you continue?
All right. Kindly confirm that you can see my full screen.
Yes, we can. Continue, please. That's great.
Yeah, all right. The country recognizes adolescents as a very special interest group, which necessitated the Ministry of Health to establish a division specifically for adolescents' health in 2008, and with a mandate of formulation of policy guidelines and manuals, coordination, amongst other roles. The current status of adolescent maternal and newborn health, with a few selected indicators, we are seeing that we have an adolescent birth rate of 135 per 1,000 live births, according to the Adolescent Landscape Analysis Report of 2019. We continue to have high teenage pregnancy rates of 24%, according to our Demographics and Health Survey of 2022, with a 28% maternal deaths contribution coming from young women aged 15 to 24 years. We have an institutional maternal mortality ratio of 62 per 100,000 deliveries, according to our maternal and perinatal death survey and response of 2023, as well as high prevalence HIV prevalence rates, which stand at 1.7 and 3% for adolescent boys and girls, respectively. We have quite a number of policies, guidelines, and tools that reflect adolescent and maternal and newborn health, but these are the most important ones as I express them on here. Our adolescent health policy standards and guidelines is of 2012. We have a draft of the adolescent health quality of care standards and guidelines as adopted from the WHO. as well as an investment case, which we call the Ramnaka-Sharpen Plan on maternal child health, which runs 2020 to 2025. We also have a family planning costed implementation plan that mainstreams adolescents' needs when it comes to access for family planning. We have quite a number of systems challenges, but under demand creation, we continue to see social, cultural, religious disparities, especially in perceptions around some critical services for adolescents. Uganda is one of the leading countries for hosting refugees, and we continue seeing also inequities in accessing adolescent MNH services in these population groups. We have a low male involvement and as well as insufficient awareness on some of the services, which makes access and utilization still low. Under service delivery and access, we continue to have prohibitive service costs, especially in the private sector, and in some instances, a poor quality of services due to health worker attitudes. We have reported stockouts occasionally, as well as a funding gap for adolescent health. Under policy, we have very beautiful policies, but dissemination is still a challenge to the last mile, as well as some inconsistent policy legal interpretations in some of the provisions, especially when it comes to the provision of some critical services like safe abortion and family planning access by adolescents. As you've seen some of the policies I presented in the previous slide, we have areas of new areas of focus, and indeed they need updating. Our response as a sector under stewardship and accountability is that we've enhanced multi-sectoral collaborations through different working groups at all levels. We've strengthened referral systems. We are currently doing pregnant adolescent mapping, as well as engaged corporate society for safe motherhood mechanism to provide resources for the procurement of logistics, critical logistics for adolescent health. When it comes to policy, most recently, given the fact that adolescent mothers are dying mainly due to hemorrhage, we've updated our standards and guidelines to include carbetocin and tranexamic acid onto our essential medicines list. As per last year, we have disseminated the Ramnaka-Sharpen Plan. We continue to provide sexuality education in schools. We've formulated a male involvement strategy, as well as outed a new structure for human resources for health to improve the staffing. Under service delivery, we've defined a standard minimum package for young people, including group antenatal guidelines and high impact practices and interventions. We have defined and developed an in-service training package for neonatal care, as well as ongoing capacity building on high impact interventions for our health workers. We have quality improvement collaboratives to manage high risk pregnancies, and that is we conduct as a country weekly maternal and perinatal death survey and response meetings across all the levels of care. So thank you. I hope I was within the time, and I would appreciate any questions or concerns.
Thank you so much, Dr. Kasose. That was great. And also to see all the work that is being done in Uganda on this issue is fantastic. We're now going to open up to a couple of minutes for questions and discussions. I see there was one in the chat box. I'll ask all the presenters to please turn on your cameras so that we can get to the questions. The first question was from Marisha about which adolescent responsive service delivery modalities are more efficient for adolescents to access quality MNH service. That was directed to you, Victoria, but all presenters are welcome to answer, but we'll go to Victoria first.
Thanks, Dr. Franazi, and thanks, Marisha, for asking the question. Really important question. So from the literature and landscape review, what we found is that parallel structures need to be avoided if we have to provide responsive adolescent MNH services. both at facility level as well as community levels. We need to be strengthening the existing systems. For parallel structures, what we found is that for some of the interventions or structures that have been put in place, we found that healthcare providers, once they are not available, then the adolescents do not receive the care and services that they need when they come to access MNH services. What was clear is that, as I mentioned, we need to be strengthening the existing systems, and home visits for pregnant and parenting adolescents, group sessions for pregnant parenting adolescents at facility and community levels were shown to be contributing to improved access to ANC and facility deliveries, as well as contributing to them being clear of what to expect at the health facility. And recently, group ANC is also showing to be an approach that is contributing to increasing responsiveness of MNH services to adolescents. Thank you. Others can chime in.
Do we have any final comments from the other speakers? I'd like to thank you all for your wonderful presentations and really to the point. But any final comments, just from brief comments from any presenters? Dr. Kasose, do you look like you wish to say something? Or Dr. Anthony and Dr. Christiana?
Yes, thank you. For us as the Ministry of Health here in Uganda, it's important for us to individualize our care according to the lived experiences and the needs of these adolescents. And as such, we define access points as four of them. And we know that we can find adolescents in the communities, we can find adolescents in the schools, we can find adolescents on digital platforms, as well as adolescents at the health facilities. So it's really important for us to tailor our interventions in the different spaces where these adolescents can be found. But by and large, we focus mainly on quality and access for us to be able to provide responsive services, including when it comes to access, including that they must participate, there must be maximum participation. So peer influences, we enhance peer influences, peer-to-peer influences amongst adolescents. And when it comes to quality, we constantly enhance the skills of our health workers. We provide feedback and accountability mechanisms at all levels of care for better coordination, as well as ensuring that commodities and supplies never run out.
Thank you, Dr. Kasose. Excellent. Thank you so much for all our speakers. We've come to time. We've gone a minute over, actually. And I just want to take the opportunity to invite you all to the next webinar, which will be on June 12th at 3 p.m. Today, we've discussed in great, with great comprehensiveness, the challenges and barriers that pregnant girls face. We had a very strong call to action by Professor Kihara at the beginning. And now the second webinar, where she will be speaking, will be about what we can do about these gaps and how we can continue to get some traction in this area. We ask all of you to continue your advocacy work in the meantime, to get stakeholders, donors, and partners on board to attend to this very neglected area. Thank you all for joining. Goodbye for now.
Thank you.